Thank you very much, Manuela, and thank you for inviting me to speak today. So, as Manuela's mentioned, my name's Elena Provenzano. I'm the lead breast pathologist at Addenbrooke's Hospital in the United Kingdom. So the UK, as many of you may be aware, has a nationalised health service that has some advantages in that there's been a big investment in digital pathology, particularly in district general and community type hospitals, because we have huge workforce issues, and digital pathology and AI is seen as being a solution to those issues. So our department is fully digitised now, but I will confess we're not routinely using the AI. My main experience with the AI has been through the trial, but I'm going to present you some of our own hospital data with respect to the trial and the types of cases where we've found this most useful. So, as already mentioned, there has been a big evolution in our approach to how we score HER2. So before the Destiny study, really we were looking for cases with amplification and high-level expression of HER2. So the 3+ cases and the 2+ cases, where the final classification depends on whether or not the FISH shows gene amplification. Of course, that's been refined now with the Destiny study that shows benefit of the antibody-drug conjugates in the group of patients with very, very low expression. And that creates huge challenges for us as pathologists, because I guess we're stretching the test to the limits of what it's designed for, but it's also focusing our attention on a group of cases where I think historically 0-1+, we didn't pay too much attention to that. That was negative. We didn't really have to agonise over precisely how to classify it. Of course, in both the USCAP and the UK guidelines, that's changed, and we now recognise this concept of HER2 low, which is the group where we have got some level of HER2 expression. It's not that high level expression that would determine positivity in terms of eligibility for a lot of the conventional anti-HER2 targeted therapies. It's these much lower levels of expression where we now know there's potentially benefit from these new group of drugs, the antibody-drug conjugates. So the specific group we're interested in are the 1+, which has that faint and incomplete stain in that 10% cutoff. And hopefully, as I'll show you shortly, it's really that cutoff that creates a lot of problems for us as pathologists in terms of reproducibility. And I think the 2+ group is a little bit easier for us because we've got that reflex ISH test that puts them into either the positive or the negative category, although ISH has some problems of its own, but that's not the scope of what we're going to talk about today. So it's all about assessing membrane staining, and there are two features of membrane staining we need to look at, which Chaim's already elegantly presented. So it's the intensity of staining, and there's I love the concept of looking at which sort of power in terms of working out the strength of staining. So as most of you know, if you've got a 3+ case, you already know it's 3+ before you put it under the microscope. You look at the tray and you can tell that it's going to be 3+ staining, although you do have to be a bit careful about the apocrine ones where the cytoplasmic staining can mislead you. The moderate intensity you should be able to see down the 10 times. If you've switched to digital, you do need to be a little bit more careful. We've found with the digital HER2 slides, you tend to see more staining, I think. So I think if you're looking at it digitally, I would suggest for moderate staining to stick to the 10 times. But for moderate intensity of staining, you should be able to easily see it and recognise the pattern with that 10 times objective. And then for the faint weak staining, it says 40 times here, but again, digitally, I wouldn't go beyond the 20 times staining. I think you then start to see a lot of artefact if you're looking at digital slides. So I find that the objective where you can definitely see the staining and interpret whether it's complete or incomplete is a handy way to help you make those decisions about how to label the intensity. And then, of course, the second decision is whether it's complete or incomplete, and in the future, we may have to disregard that 10% cutoff, which I think may be useful for a lot of us, because there's a suggestion that even cases with very low, less than 10% weak expression may also benefit from these new drugs. We're waiting for the results of the DAISY trial to show us that. So the HER2 low group is a significant proportion of cases. It probably represents around 45 to 55% of all breast cancers. And we have assessment challenges. So I will briefly touch on technical reproducibility, because obviously that's the elephant in the room. Tissue quality is very important. We know you get different results with different antibodies and different staining protocols. And I think where the AI is going to really come in and help us is with the reproducibility and interpretation. So one of my roles, I'm an external assessor for NEQAS, which is our National External Quality Assurance Scheme, looking at immunohistochemistry. And obviously we've had a HER2 module for a very long time, but we decided it was very important to have a specific module targeting the HER2 low staining. And the results of this have been really, really interesting. So we've got 45 laboratories who have enrolled for this pilot scheme. And what happens is they get sent around a slide that has 4 tissue samples that have got predetermined levels, particularly focusing on 0, 1 plus and 2 plus cases. They get sent round to the labs stain them using their own protocol, provide the lab's own interpretation of the staining, and then it's sort of sent back to us for review. It also includes a cell line control on that same slide. So we have a validated control to use as well. So the vast majority of labs are using the 4B5 antibody on the Ventana platform, and of those using the recommended test for this context, 56% achieve the expected results in all 4 tumours. There were 6 labs using an alternative or sort of like a home brew type test, and none of those achieved the expected results. What we were seeing was much better results using the 4B5 antibody, although obviously if you use a different test and you fully validated that, that's perfectly acceptable. For this particular run, you can see the way the interpretation works. So the first case was a 1 plus case. There was 41% agreement with the reference result. The other was in that ultra low category, so 1 plus 0, around 47%. The complete negative, perhaps not unsurprisingly, was the one with the greatest concordance at 83%, and then there was a 2 plus case where 42% had the expected staining results. So overall, we were a bit surprised that these are all labs who are doing very, very well on the routine HER2 module, but less than 50% were getting the expected staining results when we looked at specifically targeting this HER2 low subgroup. And as I've mentioned, the overall HER2 module, about 2/3 achieve an excellent result and a further 20% an acceptable result. So we've got a pass rate of, 88%, almost 90% with the standard HER2 module looking for the high-level staining, whereas if we specifically look at that HER2 low testing, only less than 50% were getting the expected result. In terms of scoring, just to present some UK data, so Chaim's already shown you the results from the study, but I think our results were very similar. This was a series of pathologists who sit on our National Coordinating Committee for Breast Pathologists, so it's experts, people like Ian Ellis and Sarah Pinder. In the UK, you may know those names, but it's also pathologists who act as QA advisors, a lot of whom come from district general or community hospitals. So we were given a set of 50 digitally scanned slides, again enriched for 0, 1 plus and 2 plus cases. The only cases where there was absolute agreement were the 3 plus, and there was poor agreement in 10% of cases. And those cases, the problem areas for us seem to be heterogeneous HER2 expression, so we're not very good at dealing with heterogeneity to score things. I think I know myself, I have a bias, our attention gravitates towards the positive areas. So I think in general we have a tendency to overestimate the amount of positive staining because that's what catches our eye. Not unsurprisingly, the other group that caused a lot of problems were cases that were close to that 10% cutoff, whether you were on giving it a 0 or a 1 plus, and then it was cases with non-specific staining like cytoplasmic staining that causes the problems. So if we combined the 1 plus and 2 plus as a group, the kappa value improved, but overall there was sort of low to moderate concordance in reproducibility. So the benefits of AI I think reproducibility is obviously going to be a huge benefit, and that relates to the improved accuracy of classification, particularly when it's close to the cutoffs. As I've mentioned, the NHS, we have a slightly different situation to in the US maybe. A lot of labs outsource their in situ hybridization, and there can be a 2 to 3 week wait to get those FISH results back. So if you've got a patient potentially waiting to start neoadjuvant chemotherapy, the oncologists and the surgeons are starting to get very anxious at that. So for us, one of the things we would be hoping is that we can reduce the 2+ cases to be able to make a definitive classification on that initial immunohistochemistry and avoid further delays in treatment. Heinz already mentioned the setup of the study. So there were, in my institution, there were 2 of us that were ground truth. So it was myself and one of our other senior specialist breast pathologists, and then we had 2 of our more junior members doing the combination of the initial review without the AI and then the review with the AI to compare the results. So that was the 2 parallel arms. So that the manual HER2 scoring was done using the digital slides. Then the readers looked at it with and without the AI. So overall, in terms of the study across all the centres, the percent agreement on all slides for the 2 experts was often quite high. Overall, it was around 90%, but interestingly, for the individual scores, it's that 1+ group that has the lowest concordance of around 86%, with a range of 75 to 93. I'm a bit surprised by the 100% 2+, I must admit. I would expect slightly lower concordance, so it's quite interesting that there was such good agreement on that. The general pathologists, slightly lower, so 77%, but still in the same ballpark. For our own series, I guess my colleague and I have been working together for a long time. I think we've inherited each other's biases. So out of the 200, we only disagreed on 22 cases. And you can see 18 of these fell into that HER2 low category. So it was either 0 or 1+, or 1+ or 2+ for the majority of disagreements. We didn't have FISH for all of them, because I think some of these were originally called 1+, but the majority that fell in this ballpark were non-amplified, so they were negative in the end. And interestingly, the 2 cases at the 2+, 3+ were both amplified positive cases. So clinically, I think the results would have been in the right ballpark, but it's just interesting that half the cases, the discordance was at that 0-1+ cutoff, which is obviously very important moving forward for patient eligibility for this group of drugs. So just some specific examples. Hopefully they're going to project quite well. So this is an example that was called 1+ by one of the observers and 0 by the others. This is what the core looked like. So you can see obvious invasive cancer with a bit of a lobular-like growth pattern. The heat map is showing all the invasive disease, so it's being picked up as invasive by the algorithm. I don't know how well, I think you can make out, there is a bit of a tinge there. So there is some definite membrane staining. This image was taken at 20 times, so it's in that weak category. I think you can see there is some definite weak incomplete staining there. But if you look at the map, so the blue circles are negative and the green incomplete circles are the weak cells. So you can see there are some cells staining, but it is the minority of tumour cells there. That doesn't look like it's reaching the 10% cutoff. And here's another area, and I think it's even harder to see, as Heinz saying, even harder for you, that there is some very faint blush in some of the cells, but the vast majority of these cells are negative. So I think it's a bit hard to see the numbers on the edge, but it's overall saying that there's less than 10%. So this is a case that would have fallen into the ultra-low category, and the reason for the discrepancy is the difference in estimation of the percentage of cells that were staining. Another similar case, so again, core biopsy, extensively involved by tumour, all being picked up by the algorithm. I think in this one, there's more obvious staining. Most of it looks like it's incomplete. That's being picked up with those circles, the green circles with the algorithm. But there's another area where there's considerably less staining. So again, this is one of those ones with heterogeneity where the difference between the two pathologists was an estimate in the percentage. And overall, in this case, the percentage ended up being just over 10%, and the AI algorithm called this a 1+ case. So it's the way the AI can assist us with these difficult cases where there's heterogeneity and getting a more accurate estimate of the percentage of cells that are showing the weak incomplete staining. At the other end of the spectrum, a couple of cases where the discrepancy was between 1+ and 2+. So again, there's the core biopsy and the heat map that's picking up the invasive component. Here, the staining's more obvious, but I think at the 10 times, it's a bit difficult to work out that it's complete or incomplete. And I know for us, that's a big challenge for the 2+ because the categories don't really tell us what to do with moderate incomplete staining. And I think our natural tendency as clinicians is, well, we've got a second test here, let's defer to that second test to give us the answer. And that, hence there's often huge variation in FISH rates or 2+ rates between centres. So you can see some of these are staining up as green with the faint, but there are some with the yellow complete dots, which is complete moderate, but also lots of yellow incomplete dots. Now, it's probably a little bit hard to see. And again, another area where there's still some staining, but less staining. So the majority of cells are unstained or faint. There's a few cells here with the yellow circles. So the overall classification by the AI algorithm was 1+, and actually the majority of cells with the moderate staining were ones that were showing incomplete, not complete membrane staining. Another similar case, so there's our core biopsy with the heat map. I think this one's even more obvious. So this is interesting. I'll sort of show you what's happened with the AI algorithms. We've gotten the similar answer for different reasons. So again, this is one where we've got moderate staining, but a lot of it is incomplete rather than complete. So I think it's that way of interpreting the percentage of completes and incompletes. So if you look at the heat map, there are yellow complete dots, but there are also lots of yellow hollowed out circles indicating incomplete staining. So the overall score was 2+. But the reason for the overall score of 2+, and I think that's why we still need to be careful, is the AI suggested there was a focal area of 3+ staining, and this was actually an area of DCIS. So it has picked out this one duct. And on the deeper levels, that was actually an area of DCIS. That wasn't an invasive focus. So they've done an excellent job, but occasionally you do need to go back and check. So interestingly, the AI has called it 2+, but the reason for the discrepancy between the pathologists was the moderate complete versus moderate incomplete. And on that basis, looking at the numbers, this would have actually have been a 1+ case. So the final case I'm going to present was the 2+ versus 3+. So again, that's the staining with the heat map. You can see why that was the discrepancy. So we have got intense membrane staining around some cells, but again, lots of cells showing incomplete staining. And with the heat map, we've got a combination of red cells or red dots, but also the yellow dots. So this is quite a heterogeneous case with variation in intensity. There were other areas where it was more obviously strong membrane staining. I must confess, I tend to be a little bit cautious if the staining's non-uniform, and in that setting I'll often err on calling things a 2+ rather than a 3+, so I get the FISH result. And I think the final classification in this case was a 2+, because the number of cells with intense staining didn't cross that threshold, but this case was amplified on FISH. So thank you very much for your attention.